Today's discussion is going to be interesting. When I say it's going to be interesting, what I mean is that it's not going to be like what we do on a regular basis. It's going to take a different twist because for me, it's very critical. By the end of this presentation, three things. You will have a good approach to the MCCQE1 exam in general. Number two, you're also going to know which resources to use, which resources you're going to use. And number three, you're also going to learn, strategies to studying. Because for me, I think that many a times we solve questions and all that, but there's a problem I'm seeing. I'm seeing that problem over and over and over and over again. So I'm going to jump right in. Why am I doing this? Why is it that today we are not just going to solve questions? We'll solve some questions, but why do I want us to do this particular thing? Because I want to give you the tools so that you can map things out yourself. Because for me, whenever you hear candidates, Dr. Brony, I don't know what materials to use. I don't know what to do. I want that conversation to stop. As a group, I want us to, be fully prepared for this exam. So what strategies are we going to use? And I'll be very glad that, as time goes on, some people can jump in and we can have a conversation, okay? Now, the QE1 exam, as I said today, we're going to maybe 30 minutes or 45 minutes, and we are done. What is the level of the QE1 exam? The level of the QE1 exam is the level of a Canadian medical graduate who is leaving medical school. That's all. Who is leaving medical school. So think about yourself. When you are about to leave medical school, what were the issues you had to grapple with? What were the topics you had to grapple with? Because what I've realized is that a lot of candidates, when they are preparing for this exam, they prepare for it as if it is the Royal College exam or it is some specialist exam. No. This is the exam candidates who are leaving Canadian medical schools, they write in order to get into residency. And so you realize that I remember when I was in medical school and I was about to leave and go and do my internships, there are some basic competencies you're expected to know. And those are the same basic competencies the Canadian system wants us to know. Okay, there are some core principles. So it is not, when we meet in group studies and then people are talking about very, very highfalutin stuff. No, it is totally wrong. And you realize that people can spend hours upon hours upon hours upon hours debating one particular topic, one particular concept, when they should be moving on and answering, or dealing with more critical issues. So this is what I want us to focus on today. First, the first tip I want to draw your attention to is the tip of time management. Over and over and over again, how many of us agree that, at times it is difficult to manage time, especially those who have tried the MCC question bank, the timed one, or those who have already taken the exam before, but for a reason, maybe did not do very well. How many of us believe that the issue of time management is a big thing? How many of us believe that? Okay, someone has said something here. True, Dr. Mahmoud. Good. So, Dr. Mahmoud, can you tell me something? What was your experience with time management? Can you tell me something? I just want to hear you. If you can just share, something small, because today I want us to really have a conversation about this thing and how we are going to ace the exam. Dr. Mahmoud, are you okay to speak or no? Because you know what?
Actually, I think it is really takes time to think about the question, read through it, and get the gist of it, what they actually want out of it. So sometimes it takes really time.
But then Dr. Mahmoud, as you said, it takes time. But do you know that you have basically 1 minute, 1 second per question?
Yeah.
In the morning session. And you realize that people don't struggle when it comes to a lot. I see that, Dr. Boni, are you doing CDM? Are you doing CDM? But in reality, CDM is not even where the problem is. In reality, people struggle with the MCQs. people struggle a lot because, you know, as Dr. Mahmoud said, you have very little time to think. Number two, there are so many concepts you need to know, and the time is running out. So a lot of candidates don't know what to do. And because of that, then they get into the habit of just choosing any answers. And what can happen then is that at times they can flag a lot of things that I'll finish and come back, but by the time they realize, the time has beaten them. Because you have a question, you have about 5 stems you need to review, and now you don't know what to do. So Dr. Mahmoud, thank you very much. And for the CDM, you have about 38 CDMs. And you have about three and a half hours in the afternoon. So after your morning session, you can you'll be given a short break, and then you can come back and come and do the CDMs. And that one is about 38 questions, and you have 3.5 hours. Some of the questions have 1 stem, 2, or some even 3. Okay. So I always say that you have at times more time with CDM than with the MCQs. So someone may ask, so how are you going to deal with the time management issue? Because for me today, we have to deal with this issue. How are you going to deal with the time management issue? How are you going to deal with the time management issue is that you need to know your stuff. Because in the exam, there's not a time for you to come and sit down and think. As soon as you see yourself spending more than 1 minute thinking about a question, you know you are in trouble for that particular question. Because by 1 minute, 1 second, you should have moved on from that question. But as soon as you are spending 3 minutes, 4 minutes, 5 minutes on a question, you know that no, things are not going well. So I encourage people, if you are going to beat the time management trap, and please stay with me because I'm coming to talk about other very, very critical things, then you have to have thorough brute preparation. Like, you know, you are literally reciting things. If you are going to do very well in the exam, we need to get familiar with the concept of questions to beat time. Beautiful, beautiful, Dr. Tim. And today we are going to deal with that. Thank you for bringing that up. Dr. Tim, okay, that was a very important question. He says we need to get familiar with the concept of questions to beat the time. So one thing I've realized you can do to help is brute preparation, crazy preparation, like you're going to war. Number 2 is continuous recitation of facts so that you are familiar with the facts. Because that, like this guy, the time is literally chasing him and he does not know what to do. He's running, he's trying to solve the questions, but the time is just beating him. So if by 30 minutes, you are now on question 15, you know you are in trouble. If by 20 minutes, you are now on question 12, you know you are in trouble, right? And being sure of your prep guide and your materials, because that is what will give you the confidence that, look, I can go into this exam within 1 minute, 1 second, I'm going to, you know, solve the question and move on, solve the question and move on. This is not a time to, oh, okay, question, what am I? And then you are spending 8 minutes on one question. No, by 8 minutes, you should be at least on question 6. If by 8 minutes, you are still on question 3, question 2, that is not good. And you know, for me, I'm very plain with when I'm counseling candidates, I go straight to the point. I don't want to beat about the bush at all. Okay. Now, number 2, and this time we're going to spend a lot of time here because this is for me, this is the meat of everything. You want to spend energy on what is important. You realize that this guy is trying to go to the gym, but he's basically lifting pancakes, right? So he goes to the gym to work out, but he's eating food which is not helping. Spend time or spend energy on what is important. And that is where I'm going to introduce you to do these 2 key things, which you will need in your exam preparation. We have the MCC blueprint and the MCC objectives. And somebody will say, what's the difference between the blueprint and the objectives? Good. Can somebody help me? Does anybody know the difference between the blueprint and the objectives? Because I see a lot of conversations on Facebook. How can I pass the exam? Oh, go and get Toronto notes. Oh, go and get master report. Oh, you can go and read this. You can go and read that. But I always say that no. My people, we are getting something wrong. So today I want to ask, does somebody know the difference between the blueprint and the objectives? Does somebody know? Have you come across the MCC blueprint before? Who can help us? Who has come across the MCC blueprint before? If you have, just let me know. But I'm sure a lot of us have been talking about objectives, so we've heard about it and we know about it. Today, I want to draw attention to something. Now, the blueprints and the objectives cover what we call the dimensions of care. And today I'm going to let you know which dimensions of care are important, which ones are not so important. And in fact, even when you are learning, where you should put your emphasis. So we have dimensions of care, we have physician activities. The dimensions of care talk about the spectrum of medical care. And the physician activities reflect the physician's scope of practice and behaviors. So I want us to look at something here. This is the blueprint. This is the blueprint through which your questions are set. And a lot of us today, we are going to use this class to set questions ourselves. So you realize that there are what we call the dimensions of care and the physician activities. And I talked to you about that. So the dimensions of care are health promotion and illness prevention. So this is where people talk about public health. This is where people talk about, biostatistics, because that is where that dimension is. And then you will also realize that we have acute care, we have chronic care, we have psychosocial. So psychosocial falls under the issue of mental health, psychiatry, in fact, abuse. So child abuse, elderly abuse, spousal abuse, they all fall under psychosocial aspects. But not only that, psychosocial aspects also focus on the psychosocial effect of medical conditions on patients. So for example, if a patient is diagnosed with cancer, what's the psychosocial aspect of it? The patient can develop depression as a result of that diagnosis. That is why if you look at something like MCCQE1 for the diagnosis of depression, one of the components of MCCQE1 is, being diagnosed with something very critical as a medical condition. Now, the physician activities are assessment and diagnosis, management, communication, professional behavior. And professional behavior is where a lot of people talk about ethics. Hey, I need to attend a class on ethics. Ethics. It is coming from the issue of professional behaviors. Okay, now let's dive into it. What does the dimension of care table mean? If you see this table, what does it mean? Can somebody help me? Has somebody ever thought about it? What does this mean? I have quite a number of doctors here. Dr. Abayomi, Dr. Alex, Bastrakia, Dr. Asma. What does this table mean? Have you seen it before? If you don't understand this table, you'll be wasting a lot of time. So I have Dr. Dr. Najwa, I have a question. I don't want to put you on the spot. Okay, you've raised your hand. Please tell me, what does this table mean? What does this table mean? Percentage of questions. Beautiful. Beautiful. That's what Dr. Alex is saying. Dr. Najwa, you raised your hand. What's your question? What does this table mean? Because when you're learning, you should know what you are really going to be assessed on in order to know where to put your emphasis. Okay? And that is what I want us to do today, so that from today, when you are preparing for the exam, you know what to do. So look, this table is basically telling you where the MCC wants to put emphasis. So ask yourself, health promotion and illness prevention, acute care, chronic care, psychosocial aspects, which of them carries the heaviest weight? It is acute care and chronic care. Acute care and chronic care carries the highest weight. In other words, not all the questions are even scored the same. At times, you can have a question, and acute care questions and chronic care questions can have a higher weight than health promotion questions and psychosocial aspects. And that's why some people say, oh, you know, my experience with the exam was this, my experience with the exam was that. And I'll come to that particular point as well, because it's very critical. So you should expect more questions on acute cases and chronic care. Now, there are some chronic cases which can have acute presentations. For example, somebody who has diabetes, that person can develop diabetic ketoacidosis. So even though it's a chronic condition, it has an acute composition. That person can develop hypoglycemia. At the same time, that patient with diabetes also has some chronic things which can happen. So I have a question. I've mentioned some of the acute things which can happen in a diabetic. What are some of the chronic things which can also happen in a diabetic? Can somebody help me? Chronic things, because you can use this table to even start setting questions for yourself. And that's exactly what the MCC wants you to do. Can somebody help me? What are some of the chronic things which can happen in a diabetic? Somebody just texted, diabetic foot ulcer, beautiful. Neuropathy, beautiful. Retinopathy. So if I have this table, acute assessment and diagnosis, here I'll put diabetic ketoacidosis, I'll put hypoglycemia, I'll put HHS. But chronic, I'll put diabetic retinopathy, diabetic nephropathy, sexual dysfunction, including erectile dysfunction. And then you ask yourself, with a diabetic, is there something critical about health promotion and illness prevention? Yes, because there's a screening thing we use for diabetes, for patients with diabetes, or there's a screening model. Okay. Anyone who is above 40 years, we're going to do A1C. How often are we going to do A1C? So you realize that this whole concept of health promotion and illness prevention is not just about biostatistics calculations. No. At times, in fact, those ones are even less in the exam, but they can take something like diabetes. So I have a question. Let's take health promotion and illness prevention. I need some people to help me. Which conditions do we usually get health promotion and illness prevention strategies for in Canada? Can somebody help? I want this to be an open discussion because I want us to understand how we are going to be assessed in the exam. Can somebody help? Health promotion and illness prevention. You can speak. Okay, somebody says infections, screening, immunization. Okay, so non-communicable diseases. What do we mean? Now, Dr. N, you said screening. What conditions do we usually do screening for? So you realize that health promotion and illness prevention, here, I can put pap tests. Here, I can put lung cancer screening in patients who have smoked for a very long time. Here, I can put mammogram to assess for breast cancer in women. But then you realize that if I'm talking about mammogram, there's nothing acute about it, nothing really chronic about it, but for psychosocial, beautiful. Someone also said colon cancer. So if you take colon cancer, pap test, lung cancer for patients who have smoked for that period of time, I'll put it under health promotion and illness prevention. We've talked about diabetes and we'll come back to that. But my main point is simple. You should expect more questions in acute cases and chronic cases. And let's look at something here. Beautiful, Dr. Zina. Now let's look at something. If you pick acute cases, you are expecting more questions. And at the same time, if you look at assessment and diagnosis, look at the weight it carries. So that means that if I pick any case, like a patient with chest pain, please follow me carefully. This is very important. For example, a patient with chest pain, acute chest pain, where should I put a lot of emphasis on? When I'm learning, I have to be able to diagnose, chest pain. I have to be able to do assessment of chest pain. I have to be able to list differentials of chest pain. I have to be able to manage chest pain. In fact, if I know assessment and diagnosis and I know how to manage chest pain, I think I'm good. I think I'm good. This is the beauty of this table. So I have a question. When it comes to cervical cancer and the rest, cervical cancer screening here. Well, if you are said, we know we have to do pap test, but then you also know what to do if the pap test comes back with abnormal cells of undetermined significance. You must know what to do. That is assessment, diagnosis. How are you going to manage that patient? If I get those two concepts right, I know I'm in a good position to do very well. If I come to chronic cases, so that's what you have to know. Look at the table very well. Acute chronic cases. What are some chronic cases which are common? COPD, asthma, okay? Asthma, where should I be putting my emphasis? My emphasis should be on assessment and diagnosis, management of asthma, diabetes, like all those things, hypertension, and then you realize that the communication bit comes down. The relatively less known questions can be health promotion, illness prevention, psychosocial aspects of care. Now, if you go to the assessment and diagnosis part, the physician activity part, you realize that you are expecting more questions on assessment and diagnosis and management, and less questions on communication, professional behaviors. This is coming from the MCC itself. Now, so the MCC objectives are based on what we call the CAN-MET rule. CAN-MET rules. And somebody will say, what is CAN-MET? How many of us have heard about the CAN-MET rules before? The CAN-MET rules is how the questions are framed. So when you are learning, you have to focus. The CAN-MET rules are simple. The physician as a professional. So for example, it will say, Dr. Gata Osadolo, is she a professional? Is she what's her communication strategy? Is she a collaborator? Is she a leader? Is she a health advocate? Is she a scholar? But you realize that all of these meet in what we call the medical expert. I'm going to show you a PDF, which everybody should have. To me, that PDF is very critical. Everybody must have that PDF. So which CAN-MET role should you focus on? You should focus on that CAN-MET role, which is the center of all these things. Please, are you following me? Beautiful. You should focus on that CAN-MET role, which is the center of all these things. And that is the one CAN-MET role which is necessary. The physician as a medical expert. Because with the medical expert role, you combine communication, professionalism, scholarly attitude, collaboration, health advocate, leadership. Okay. Now, the CAN-MET role you should put all your emphasis on is the medical expert role. Because if you get the medical expert role right, the rest all fit into it. Spend more time there. So today we are going to look at how to map each objective to the blueprint. Because this is what is going to help you to ace the exam very well. Okay. So let's use diabetes as an example. Diabetes objective 37.2. How am I going to ace the exam using the CAN-MET role and then, the framework? How will I know that what I'm learning is relevant? So what falls under each dimension? You realize that when you are using the MCC objective very well, under assessment and diagnosis, and I want to go back to that thing because you have to see it all the time. Under assessment and diagnosis, in health promotion and illness, you have to focus on screening for diabetes. So you realize that if you keep this table with you all the time when you are learning, it will help you to be able to even think like the way the examiners are thinking. Screening for diabetes. Number 2, when it comes to management and acute care, you could get a question which could focus on initial management of a patient who is presenting with diabetic ketoacidosis or HHS or hypoglycemia. And then if you get to under communication and psychosocial aspects, a question could focus on counseling a patient who is unable to afford their medications and testing supplies. So you realize that this can fall under ethics this can fall under preventative medicine or and advocacy because it is a CANMET rule. This is how the examiners want you to think. And I'm getting all this information from the Medical Council of Canada itself. They gave this example. So why aren't we using these strategies in our learning? And then we go to a group study and people are battling over, very, very highfalutin stuff, which in reality has no meaning in the exam. And when I hear some of these things, it makes me laugh because I go like, you know what? It's very sad that people, spend all the time, all their precious time, thinking about, some very, very deep, complex things. Meanwhile, the exam is at the level of a medical student, and the exam wants you to get certain things right. Okay, so let's try something. Let's try this dimensions of care thing, so that you know how you're going to do this. So, objective 2.4, that is hernia, abdominal wall or groin. Can somebody volunteer and take us through how the person is going to map out the strategy for this particular thing? I want somebody to volunteer if it is possible. I just want somebody to volunteer. Health promotion, when it comes to hernias, do you think we need to worry ourselves with health promotion and illness prevention? Does it really jive with you? I don't think so. I don't think so. What about well, Dr. Ennis, but smoking, sure. It's when you're talking about smoking in the context of smoking cessation, and at times like wound healing and the rest, sure. Okay. What about acute? What can abdominal wall hernias and groin hernias fall under that acute presentation? I think so. And what are some of the acute presentations which can occur in a patient with hernia? Can you help me? Gangrene, beautiful. Gangrene, what else? Strangulation, beautiful. I like the way, so you see, look, if I were you, I can easily predict which questions they can ask me for abdominal wall and groin hernias. Because where are they going to put a lot of emphasis? Acute, assessment and diagnosis. So number one, how am I going to obstruction? I wish Dr. Enes was the one teaching. Dr. Mabud, beautiful. Is it strangulated? Is it obstructed? Is it incarcerated? And then the chronic parts can be, what are the things which can cause hernias to recur? Hernias to recur. But you realize that when it comes to communication, what do you, when it comes to management, what do you think they can be asking you about hernias? They can focus on maybe a patient has come to the ER with swelling in the right groin, and now the patient is having maybe vomiting and abdominal distension. What is your next line of action? Maybe you will say, maybe they can say abdominal X-ray, abdominal CT, call the surgeon right away, give Tylenol, and the last point can be send the patient home to be assessed by a family doctor. What do you think the answer will be? I'm asking, what do you think the answer will be? No, Dr. N did not ask about ABC. I'm just giving you objectives. Number one, send the patient for CT or ultrasound. So this is the question. A patient noticed right groin swelling while playing a game. The patient has started vomiting. The patient has abdominal distension. The patient's blood pressure is now about 80/60. What's your next best step? Abdominal CT scan. Call the surgeon right away. Send the patient home to follow up with family physician. Abdominal X-ray and give the patient Tylenol. People are saying, beautiful, Dr. Tahir is right. Call the surgeon.
Call the
surgeon. In fact, you shouldn't even go for abdominal ultrasound. Call the surgeon. You see the way a lot of us are getting these things wrong. Because a lot of people are saying abdominal CT. The patient is unstable. Why are you sending the patient to the tunnel of death? CT scan, we call it the tunnel of death. If a patient is unstable, don't send for a CT scan. If a patient is unstable, don't send home. So if this thing I gave, if it was in a CDM, sending the patient home will not only be 0 for that particular point, you get a whole point 0. That's beautiful. Dr. Mario said it's a clinical diagnosis, because if a patient has hernia and the patient now is vomiting, has severe pain, it is nothing but a clinical diagnosis. And this patient needs to be seen by the surgeon right away. Beautiful. So my point is simple tonight. Not every objective will map to all the categories of the blueprint. Not every objective. And that is the truth. Not every objective. And I'm going to share with you this PowerPoint, or no, not this PowerPoint, a PDF, which you must have. You must have this PDF. It's an 8-page PDF from the Medical Council of Canada. You know, they took the various conditions and they put them under the medical expert rule. You know, I know we have the objective 1, 2, 3, 4, 5, but this one, this is what the Medical Council of Canada wants you to know. Abdominal and pelvic masses, abdominal distension, abdominal pain, abnormal heart sounds and memories, abnormal liver function test, abnormal serum lipids, acid-base abnormalities, allergic reaction, anxiety, ataxia, attention, learning, and school problems. If you cover these topics under A, forget about every other topic under A. You've covered everything they want you to cover. Seriously, trust me. Number 2, let's go to B. What are the high-yield topics there? Blood from the gastrointestinal tract, so upper and lower GI bleed. Blood pressure, so blood pressure in children, blood pressure in adults, blood pressure in pregnant women, and hypotension. That's a shock. So you have to know the types of shock: hypovolemic shock, obstructive shock, distributive shock, and neurogenic shock. If you cover that, you are good. We go to the next B, blood in sputum. So you have to know the differential diagnosis. We go to the next B, blood in urine and hematuria. We go to the next B, breast disorders, including breast discharge, breast masses and enlargement. That is where breast cancer comes. If you cover that, you are good. Then you go to burns. If you go to burns, you are looking at the modified Parkland formula. You are looking at indications for referral for a patient with burns, like more than 20% body surface burn in a 3rd-degree burn. For example, burns over joints. For example, inhalational burn. What are you going to do for a patient with inhalational burn? Literally, you can have an air view of everything you need to know for this exam with just this alone. Let's go to C, calcium and phosphate concentration abnormalities, cardiac arrest. This is where your ACLS comes in. So how are you going to manage a patient with pulseless electrical activity? That's the right side of the ACLS algorithm. How are you going to manage a patient with I said pulseless electrical activity, VFib, VTAC, you know, those ones you have to know. When will you start CPR right away? Those things. Which of them will you do CPR? Which of them will you do amiodarone? Which of them? What are the H's and T's? The reversible cause of cardiac arrest, you must know. Now, the next C, cerebrovascular accident and transient ischemic attack. How to identify stroke. What are the differentials of stroke? What are the mimics of stroke? Then, even with stroke, you have to know, the circle of Willis. Where will you get a lesion and how will it present? Chest pain, you have to know the differentials of your chest pain. The deadly causes of chest pain. You must be able to recite it. Coagulation abnormalities, constipation in children, in adults, medications which give constipation, especially opioids, contraception. So oral contraceptive pills, emergency contraception. What are the types of emergency contraception you should know? Please, doctors, are you tracking with me? Today, I really want us to demystify this whole MCCQE1 thing, which is beating people on the head. So what are some of the other things you need to know? Cough, contraception, and under cough, you need to make sure you've covered asthma. You need to make sure you've covered COPD. And cough in children. Cough in a child is aspiration of a foreign body until proven otherwise. That is it. You have to deal, it is under cough that you're going to deal with things like croup, laryngotracheal croup, tracheitis, like all those things. That's what you're going to deal with it. Cyanosis, this is what you're going to do with your 5 T's. The 5 T's, cyanosis in children, tranquillosis, total anomalous pulmonary venous insertion, tetralogy of Fallot, transposition of great vessels. This is where you are dealing with it. We're going to go to developmental delay. This is where you're going to deal with Down syndrome. You're going to deal with, all the spectrum, diarrhea, chronic, acute diarrhea. You're going to deal with traveler's diarrhea, pediatric diarrhea, calculation of fluid requirements in a patient, in a child with diarrhea, diplopia, dizziness and vertigo. How are you going to know that this patient has benign paroxysmal positional vertigo? What special test do you do? What management do you give? Dysphagia, you're going, this is where you have to learn the oral form of dysphagia and the endosophageal form. And what are the things which separate them? Dyspnea. Doctors, this is a PDF you need. Everybody needs to get this PDF. Ear pain, otitis media, otitis externus. I don't want to waste your time, but if you get this 8 parts PDF from the Medical Council of Canada, that is awesome. Then the next thing, use the MCC's practice test. Please, please use the MCC's practice test. And especially use the timed practice tests. Not only, what your friend has given you, screenshots your friend has taken. No, invest money. Go to the MCC website, and that is the link. If you want it as well, I can also put it in a Facebook group. So you can click it and go there. Go and buy it. Practice those questions. Look, we want to be doctors in Canada. Being a doctor does not come easy, but it will be worth it. So invest in your education, invest in your progress. That's all I can say, Good. Now, how will you be scored? Because this is also very important. And what are you supposed to watch out for? You'll be scored based on 2 things. Number 1 is the question's individual scores. And number 2 is the level of difficulty. As we learned initially, not all the roles have the same weight so far as the examiners are concerned. In the same way, not all the questions have the same weight. And not all the questions have the same level of difficulty. Now, this is something I want to tell you. There are people, and I'll be showing you a quote from a colleague, like somebody who came to me. I will say this: if you keep getting easy questions, be careful. Something is not right. If in your exam you keep getting easy questions, be very careful. If you keep getting, that's number 1. Number 2, if you keep questions being repeated around the same topic, be careful. Because in reality, the whole concept of the exam is that they want to spread the objectives as much as possible and test you in various objectives. Of course, they can't test you in all the objectives, but as many objectives as possible. But if while you are doing your exam, the questions keep getting easier, and it looks like they are asking questions around the same topic, and maybe you do question 5, and by question 8, another question, be careful. What do I mean by that? As you are scoring good, as you start the exam and you are doing good, it's a computerized system. The level of difficulty starts changing. If you realize that they are taking you into different systems, like, it's like, these questions are becoming tough, chances are that you are doing well. But if all of a sudden you realize that, like the question has become so easy for me, you should be careful. I don't know whether those who have written the exam before and maybe something happened that they didn't go, they can testify to this. In fact, I have somebody who said, Dr. Bruni, I don't get it. This is the easiest exam I've written since medical school, yet I failed. Why? And my answer was simple. While you were writing the exam was telling you were failing, but I didn't know. You didn't pay attention. Not everybody in the exam gets the same questions. No. You may be sitting here, you may be writing the exam, and there's somebody sitting by you. The two of you, don't ever think that the two of you are answering the same question. Depending on how you are performing, the questions may be changing. If you are getting easy questions, like, I don't know how to put it, but very easy questions, not a good sign, not good. But as you answer the questions, things start getting tough and you are sweating a little bit and you realize that this is not normal. Chances are that you are doing very well. So that's one thing I want you to also pay attention to. Not so if we are writing an exam on one day, not all the candidates are getting the same question. The candidates who are doing well are getting tougher questions. The candidates who are not doing well are getting easier questions, and they'll say, oh, the exam was very easy. And then results come, oh, what happened? I don't know. I got very easy questions, but I didn't do well. This is the secret. How will you be scored? The lowest score you can get is 100. The highest score anybody can score is 400. The pass score is 226. But let me sound this word of caution. You realize that it is not enough to just pass the exam. Now, I'm going to show you some statistics. I know I've shown it in the past classes before, but I will show it again. It is not enough to pass, just have a pass, because there are so many people who have a pass, but they can't do anything with the pass. And the painful thing is that when you pass, you can't also take the exam again. So that means that, in fact, you are better off failing the exam than passing with 225 or 226 or 228. You are better off failing the exam. Why? Because you get opportunities to write it again. If you pass with 226, you are stuck. It will take a miracle to get a residency. Like, it is tough. And I'm not saying this to scare you or anything. I'm just trying to let you know the reality on the ground. So you realize that results come, oh, I've passed, oh, I've passed. 5 years down the line, that guy who was going, oh, I've passed my exam, has still not gotten into any residency position, has not gotten into any practice readiness assessment position. Why? Because a pass is not enough. The exam has become increasingly competitive. What do I mean by that? For example, I want to take you to 2021. In 2021, the least score for the CMG group, that's the Canadian Medical Graduate, was 229. The least score, that is the one who did not do well at all among the Canadian Medical Graduates, was 229. The least score among IMGs was 100. That means the person who got 100 is like 0 in the QE1 exam. So you ask yourself, as of 2021, there were some IMGs who could not get even 101. Why? Because they were unprepared. That's the truth. I don't know. I want to pause here. Does somebody want to say something? Does somebody want to ask a question? I want to ask. Does somebody want to say something or ask a question? If yes, let me know. You can raise your hand, or if you have a question in Facebook as well, you can put it there and then we can deal with it for you. Does somebody want to ask a question or raise a hand and say something? Okay. If not, let's continue. The least score among the IMG group was 100. What's the question? Around how many percent of test takers achieve more than 226? Okay, I'll show you that. Dr. Robert, I'll show you that. Now, the mean score, is the question set up the same for both though? Yes, the question is set up the same for both. But as you are doing well, it is individually basis. As you are doing well, you know, the question gets harder. As you are performing poorly, the question gets easier. Well, Dr. Najwa says he doubts if the questions are set up for same both. Well, but from my experience, I think so. Now, look at something here. You know, when a typical IMG gets 268, the IMG is happy. But the mean score, that is the average score for the CMG group, was 268. Can you imagine? If anyone who gets 268, at least you know you are going to get a residency interview. At least you know you're going to get and chances are that you are going to get a residency spot. The mean score for the IMG in 2021 is 232. And someone is asking, do you know why there's a big difference between CMG and IMG mean score? Yes, because the CMGs are scoring very high. Can you imagine? Let's go back to this. While you are trying to score 300, another IMG is scoring 100. It will bring you down. But look, the least score for the CMG is 229. So if they also get people who are scoring 300 and above, which they did, you realize that it pushes them up. That's the beauty of it. And the reason why IMGs are scoring so low is because we don't know how to prepare very well. We are not using the CANMET rules. I don't think CMGs are using, you know, anything different. I teach CMGs all the time. I teach them all the time. They are using they are using the same material, but they are thinking differently. That's the difference. I teach CMGs in my practice. I teach medical students. I teach residents. They use the same material. Yes, they are not using any hidden materials. In fact, if you ask them, they don't even know, you know, they can't really tell you, go and get this or go and get that. No, they are using the same materials as IMGs. But why? Because they've been in this system, they've been taught right from, you know, year one up to where they are going to write the exam. Yes. Meanwhile, an IMG will come, the IMG is still working, you know, in whatever field, whatever we are doing. And I know the battle is tough, you know. We've come with families, we've come with a wife, we've come with a husband. We need to, and some of us get here, we get pregnant, you know. But then the CMG typically has a lot of support because that's the person is coming from here, right? They are using the same money. Yes. And then the CMGs are also trained using the Canadian guidelines. So you see, you have a lot of gap to fill. But the typical IMG thinks that this exam is about just knowledge, but it's not just about knowledge. QE1 is not just about knowledge. It's about common practice. Okay. And in 2021, there was 100% pass among CMGs, 100%. Because as I said, the list was 229. That was a pass. The pass rate among IMGs was 60.8. And I can tell you for a fact that even that 60.8, maybe just about 20% or 15% will get an opportunity in residency positions and the rest. So you see, can you tell what score can be considered as a good score? Sure, I'll tell you that. So you realize that, like, you know, we meet as IMGs and, oh, what can I do? I don't know. I've already passed my Q1. The person will say, I've passed, until you ask the person, what score did you get? The person will not be able to tell you. Why? Because that score can't get the person anywhere. So Dr. Mabud is asking about what score will you consider good? In the times in which we are, aim for something above 270, 260 and above, 270. If you start hitting 300, you are good.